Folks, thank you so much for joining us today. I'm Gabe Horwitz with Third Way, and I'm really excited about the panel that we have set out for you guys today. Kidney disease might sound like a niche topic, but more than 1 in 7 US adults has chronic kidney disease. African Americans and Latinos are especially vulnerable, and almost 800,000 people have what's called end-stage renal disease, or ESRD. And this is the final stage of chronic kidney disease. And these folks need help. And unfortunately, COVID has only made them more vulnerable. Now, though recently, there's been a lot of policy action on kidney health. Last year, the administration launched a kidney health initiative to improve care for patients. Medicare Advantage enrollment is opening up for patients with ESRD. And there are several bills in Congress related to kidney health. And that's why I'm really excited to get into this issue with our guests today. We're going to discuss key issues like care coordination, disease prevention, value-based payments, and we'll also review the outgoing administration's initiative on this issue. And like always, we'll have time for Q&A. So here's how this is going to work. First, we're going to talk to one of the key congressional leaders on this issue. And you may have noticed the Hill is dealing with a couple of things at the moment. So we're not going to keep Congressman Blumenauer long, so he can drop off. Then we're going to dig into these issues with a panel that I think you're really going to enjoy. So let's jump in. It is a real joy and a real honor to have Congressman Earl Blumenauer with us. He's an incredibly thoughtful member in the House and a real leader on health issues from his perch on the Ways and Means Committee. And I'm sure he's going to talk about it, but he's got a bicameral bipartisan bill called the Better Kidney Care Act that would create a Medicare demo to deliver integrated and coordinated care to folks with ESRD. So Congressman, thank you so much for joining us. Let's dive in. I'd love to just start broad. What's your view on the state of kidney care today, and how would you improve it?
Well, you referenced early on, Gabe, the numbers, and being in this COVID crisis accelerates the disparities that we've got in terms of care, the strains on the healthcare system, and at some point we're going to sit down and we're going to look at costs. Kidney care is something that you're right, doesn't get the appropriate attention that it deserves, and there are real opportunities, I think, to take advantage of the pattern of care that we have now. I am pleased to work with Senator Young. He was a seatmate of mine on the Ways and Means Committee, and we started exploring this, convinced that there was a better way that we could meet some of the most fragile patients. Again, 750,000 people suffer from end-stage renal disease. They have a number of conditions. They are captive for maybe 12, 14 hours a week, 3 times a week. Our conclusion was that we could take advantage of that situation to be able to provide better care, that we wouldn't have to shuttle them around for other doctor's appointments. I mean, this is, for a number of these patients, just moving is a challenge. So we've been working now for several years with a variety of stakeholders, certified smart people, others in Congress. We've been able to engage others in this challenge with Representative Smith and Senator Sinema. It is bicameral, it is bipartisan, and over the years we have met countless times with stakeholders trying to listen to concerns, to assuage them, and be able to focus on the desire to have a pilot project that could show what we could do if we were able to do it right.
Congressman, how do you think the administration, the current administration, has done on this issue?
Well, I am no fan of the Trump administration. They've been reckless and posed all sorts of problems. Their crusade to end the Affordable Care Act, I think, was misguided and almost laughable, but it's done real damage. But this is one area where I think they've moved in the right direction. attempting to encourage their reforms. I think it was in the right direction. There are things here that we can work with to build on. Everybody recognizes that these are vulnerable, fragile patients. Everybody knows that there are things we can do dealing with transplantation, other alternatives in terms of how the dialysis is delivered, how we deal with upstream and downstream consequences of kidney disease. My friend Congressman Kind had legislation, which I hope will ultimately be approved by both chambers, dealing with lifetime coverage of immunosuppressants, that to be able to make sure that the healthcare reform, the treatment that people get lasts a lifetime. Simple, common sense, but this is complicated, and there are lots of people who have their fingers in the pie. But I'm cautiously optimistic that the stage is set for some real progress in the Congress ahead.
That's great. And then is obviously President-elect Biden and Vice President-elect Harris think about what they need to either continue on from the Trump administration or radically change. Obviously that we can spend the next week talking about all those issues within healthcare, but within the kidney care space specifically, do you think they should be continuing on the administration's work in this area?
I think this would be an area that they could pick up and work to refine, expand engagement with stakeholders, and take some of our other provisions to put in there. Team Biden has some terrific people in the healthcare space. I've had conversations with Atul Gawande about some of this. I mean, these people are knowledgeable, and this is an area that is not partisan. We've got the opening with Trump. We've got the opening of bipartisan legislation. I would hope that they would pick up where the Trump administration left off and build on it, because it would make a difference for hundreds of thousands of patients and their families, opportunities for massive cost savings over time by giving people better care. And I hope they pick up where the Trump administration left off.
You mentioned a couple of times this is a bipartisan issue. And I think there's a lot of people thinking next year we're probably going to have divided Congress. What do you think is needed to actually make more progress on this issue next year? Do we need more ideas? Do we need more support? Do we need more effort in Congress? What's the recipe there?
Okay, I am a strong believer in using the opportunity to, we don't have to hit grand slam home runs. There are no shortage of really great, grand ideas. But we've got lots of suggestions that would make a difference and wouldn't be earth-shaking, but they would show progress. You know, I don't want to hit a grand slam home run. I will settle for a single or a double. I mean, I think this legislation that Senator Young and I have is a good, solid double, but I'd settle for getting hit by a pitch. The idea is to build momentum, to show that we can work together, and to deal with so many elements of the healthcare arena that is not polarized, that doesn't matter whether you believe in the Affordable Care Act or not. These are areas where we can mark progress in a nonpartisan fashion, and that there's enough space here that we can craft solutions that can be inclusive. And I think that is the name of the game. Let's show that we can work together and make progress. I have great confidence in my partner, Senator Young. I think if people will work with us on this legislation, we'll do something that'll help hundreds of thousands of people, that will provide better care, a model for going forward, and saving money rather than costing money.
Yeah, I'm feeling optimistic. You've sold me. Let me ask you though, because there's obviously going to be some legislation that passes in the coming days. At least we hope so. Any chance we can see any sort of kidney care movement and any sort of year-end package in your mind?
I think that's a long shot. There's so many moving pieces now. This is an area we've talked about where there's been progress, where people are coming together. We have spent hundreds and hundreds of hours meeting with all manner of stakeholders to be able to raise the comfort level, because there are moving pieces and people are apprehensive. I would much rather take a little extra time in the new Congress and use this as a building block than to try and jam something through in the final minutes, which may not be fully ready for prime time. And I don't want to be in a situation where we raise more questions than we settle, or that we create problems that we have to go back and solve. A little extra time, I think, will help us get this right. And I think the stage is set for something that is not ideological or partisan. It just makes sense.
Sounds great. Listen, I know you are an extremely busy guy. I want to just thank you for spending a couple minutes with us here today. Good luck to you over the next couple of days as you sort through all these big COVID relief and budget bills. And thank you for your leadership on this issue. I know I speak for Third Way and many others on this phone when we say we want to work with you next year, and we're just really pleased to see all your work on this.
Gabe, I appreciate that. And I do appreciate the focus on this area of healthcare that doesn't get the attention that it deserves. And I think this is a step forward that I salute. Thank you very much.
Take care, sir. On that note, I'm going to ask our other panelists if they'll pop their cameras on and come off mute. Fantastic. Gentlemen, thank you so much for joining us today. It was great to hear from Congressman Blumenauer, and now I'm really excited to get into some more details with our next group. So let me tell you who's joined us today. Andrew Conklin is president of Dialysis Patient Citizens. We've got Dr. Larry Weisberg, who's head of nephrology at Cooper University Healthcare. And Dr. Stanley Crittenden is the National Medical Director for Nephrology and Kidney Disease Prevention in Anthem's Diversified Business Group, CareMore and Aspire Health. Thank you all so much for joining us. And here's what I want to do. I think Congressman Blumenauer really set this up well. Let's first spend some time getting into the problem that we're facing. Then we'll turn to some solutions and open it up to questions from the audience. So for the folks in the audience, if you want to ask a question at any point, feel free to submit that using the Q&A button at the bottom of your screen. I'll get those. I'll do my very best to ask as many as we possibly can. So let's just dive right in. Andrew, I want to start with you. Now, you have ESRD, and yes. I'd love if you could just help explain some of the biggest problems that you and other patients experience with your care.
Okay. Well, I've been on dialysis for about 17 years. I was born with spina bifida, and I was only born with one kidney. So that has led to a host of problems I'm sure you can imagine. But like I said, I've been on my dialysis for about 17 years. Unfortunately, I'm not an eligible transplant candidate. So dialysis is my way of life for the foreseeable future. I'm also got the additional problem of I have a vein issue where I'm not able to get a traditional access of sticking in needles. So I am stuck on a catheter for the rest of my life until we can find something better to do. So that's always been a challenge. Then, of course, you have the regular challenges of dialysis, the low blood pressure, cramping, fatigue, then, of course, transportation issues. All of those things add up, and it's kind of a maze for most dialysis patients to try to figure out insurance, transportation, and not feel well on top of everything. So those are the major issues, I think.
And Andrew, is that experience typical for ESRD patients? Have you heard of other things that they're experiencing as well?
Those are the very typical in most dialysis and ESRD patients. Then, of course, you have diabetes and high blood pressure and some of those contributing factors. Of course, those have their own problems that go along with ESRD as well.
Yeah. Larry, let me turn it over to you. Can you explain a little bit about the initiatives that have recently come out of the administration? And I'd love to know how providers are feeling about the possibilities for improving care with these new initiatives.
Sure. So as part of the Advancing American Kidney Health initiative that was announced by Donald Trump in July of 2019, there were several proposals, but I mean, the main goals were to try to improve the healthcare for people with chronic kidney disease and end-stage kidney disease. And the main objectives of the initiatives were, number one, to slow the rate of progression of chronic kidney disease so that fewer people who have chronic kidney disease develop end-stage kidney disease like Andrew Conklin, right? And that would require a better education program to actually identify people who have chronic kidney disease, because the majority of people in this country who have chronic kidney disease don't even know they have it. It's a silent disease until it's far, far advanced. So number one, slow the progression of chronic kidney disease. Number two, increase the rate of transplantation. That is, move people who would otherwise be on dialysis to get a kidney transplant and allow them to live a life that's completely independent of dialysis. Number three, for people who actually require dialysis and are not able to get a transplant, at least immediately, have more of those people get their dialysis at home. So the overall goal was by 2025 to have 80% of people who have reached end-stage kidney disease either have a home dialysis modality, use a home dialysis modality, or get a transplant, 80%. So where are we right now? We're at about 12%. 12%. If you combine transplant and home dialysis, you get about 12%. So we can talk about why that is and where we could go or how we could try to improve that. But the specific programs that were developed by CMMI in order to begin to achieve or to move in the direction of those goals are several. So there's what's called a mandatory model, which is the end-stage kidney disease treatment choices program. That's a mandatory model where if you get selected, if you as a provider get selected to be in this program, you have to be in this program. And there are incentives built into this program to incentivize transplantation and home dialysis. I'm not going to go into the details, but you get selected, you're in it. About 30% of providers around the country have already been selected to be in that program. And then there are two categories of voluntary models. One is called Kidney Care First, and the other one is called Comprehensive Kidney Care Contracting Model. Both of those are value-based payment models, and they're constructed differently. But the idea is that if you decide to enroll in them, you agree to assume care for this population of patients with chronic kidney disease and end-stage kidney disease that you take care of. Under certain parts of those programs, you can assume responsibility for the cost of care, the total cost of care, or some slice of the cost of care, while providing comprehensive care for those patients in order to improve quality of care and reduce cost at the same time that you're achieving the goals, the overall goals of this Advancing Kidney Health initiative, that is to increase the rate of transplantation and increase the rate of home dialysis. So that's
extremely helpful, and I could ask you 40 more questions based off that, but let me just ask you one, and then I want to move over to Stanley. Larry, do you have a sense for how providers are feeling about those, both the voluntary and others? Is there, and I know you can't speak for everybody, but just from the docs that you talk to, what's their sense of this?
The docs that I talk to are people who are exploring the possibilities right now. Right now, you don't have to, unless you've been selected to be in the mandatory model, you're kind of running some models to see what your participation in any of these voluntary models would mean financially and whether you could actually achieve the goals. So right now, people are approaching these with a certain amount of circumspection and skepticism, trying to understand whether they could actually achieve the goals that are proposed to be achieved by these models, and whether they're not going to lose money as a practice by participating in these models. It's not totally clear. It's not totally clear. They're very complex, and the finances are extremely complex.
That's helpful to know. Stanley, let me turn it over to you. From a health plan perspective, what challenges have the health plans seen in care for patients with kidney disease in your existing programs?
Thank you, Gabe, for the question. And thanks for having me here, by the way. And really thank you to Third Way for hosting this important conversation, allowing me to participate. I'm excited right now. As a frontline nephrologist and a managed care physician, I'm just so excited that kidney care is really now front and center in the national conversation. Anthem is a national leader in national health plan, and we have many innovative tools and efforts underway to improve clinical quality of care for patients with both end-stage renal disease and with chronic kidney disease. Despite that, though, we have some headwinds, but we also have some wins and successes. So let me just take a second to tell you about what we do here at Anthem and CareMore. So with our Medicare Advantage Chronic Special Needs Plans, or CSNPs as they're known, we've been successfully taking risk on the total cost of care for patients and their clinical outcomes for quite a many years, and we're closing lots of quality and care gaps while doing this. Our CSNPs are hosted by CareMore, and CareMore is an innovative, complex care delivery organization, really focused on taking care of Medicare members with multiple and complex medical comorbidities. And like I said, we've been doing this for about 25 years. At CareMore, our model is quite unique in that we deploy clinical programs and services for patients needed the most. And we use interdisciplinary teams of both clinicians and non-clinicians. And so when I say clinicians, I mean nurses, doctors, pharmacists collaborate with non-clinicians like social workers, community health workers, and we're all aligned and coordinated in our team approach for the sake of the patient. And our interdisciplinary team is different than the traditional healthcare model that we all kind of come to know in the fee-for-service world, in that it usually is very fragmented and inefficient. We try to break down those barriers. And then we add in things like technology pieces like remote patient monitoring, telehealth, and then other pieces like transportation and home-based services to address some of those social determinants of health that are so common in our end-stage renal disease population. And we like to think of that as our special sauce. At CareMore, then, we have this coordinated team that develops a comprehensive plan of care with our patients in conjunction with our nephrologists, our dialysis partners, to really manage the unique needs of dialysis patients. And like I said, even though we have this fantastic program, we certainly still have some headwinds. But let me just highlight a couple of successes first, and I'll highlight some of our headwinds. A recent study that was published in Health Affairs back in August compared CareMore's ESRD CSNP enrollees with original Medicare fee-for-service data, and that found that our CareMore ESRD patients had a much lower mortality rate and much lower rates of acute care utilization and hospitalization, on the order of a 37% reduction in acute inpatient utilization. If anyone would like a copy of the study, I'm happy to pass it along. But we're super excited about that because that success is really adding to the growing body of evidence that CSNP models are really a good, effective alternative care delivery and financing model for patients with end-stage renal disease. And that improves their clinical outcomes, and it also improves their total quality of care. But as I mentioned too, we're happy with our model and we're happy with our results, but we do know that there are headwinds and areas that we can improve. One of the limitations of ESRD chronic condition special needs plans, or CSNPs, is that enrollment's limited to patients who already have ESRD. And as we think about developing true end-to-end kidney care solutions, we know that it's imperative that we go upstream and that we manage patients at risk for progressing to ESRD. That is, we need to find patients better and more efficiently with chronic kidney disease. I know folks have already mentioned the American Kidney Health Initiative, and we're directionally aligned with that. But we would like to also think about ways to include at-risk members with CKD in our CSNP models, for example, given those results that I just mentioned that were published recently. So in terms of challenges and headwinds, we would really like to just think about how to encourage more proactive management of CKD. And I know some of these new payment models are attempting to do that, but already within the framework of an integrated Medicare Advantage plan or a care delivery organization like CareMore, we can do a lot to delay progression and halt progression of disease if those patients are in our programs. And then we can provide them easier access to things like home dialysis modalities, like peritoneal, like home hemodialysis, and really go upstream so that we can actually expand the number of kidney transplants by doing a preemptive evaluation way upstream before they even are ESRD. And we all know that patients who are end stage, who have transplants or who are on home dialysis therapies like peritoneal or home hemodialysis, avoid a lot of adverse outcomes that are associated with in-center dialysis, and they have improved quality of life scores. So those are some of our headwinds, but we also have some successes along the way with our ESRD population.
Thank you so much for that. Let me turn to a question from the audience, and I'm going to do my best with some of these acronyms, so you're going to have to all excuse me. Question is about initiatives to encourage novel drugs and devices to address the needs of ESRD patients, specifically regarding incentives at the developmental stage, such as QIDP under the GAIN Act for anti-infectives. Are there some of these initiatives out there? Are they successful? I pose that to the group.
Yeah, I can talk about that a little bit. There is a joint program between the American Society of Nephrology and the Food and Drug Administration, and I believe the NIH is participating in this as well, called Kidney X, which is an innovation accelerator program that's meant to be a sort of public-private cooperative to accelerate the innovations in the kidney world. And a number of, so there's a lot of grant money that's been put together by the American Society of Nephrology and some federal money and some private money in order to encourage this development. And a number of relatively small projects have come out of this so far, but people are pretty enthusiastic. I mean, the recognition is that there's been very, very little in the way of drug and device innovation in the care of focused on the care of patients with kidney diseases in the last several decades, because kidney disease is relatively underfunded, especially at the NIH level. So this was an initiative to try to really boost innovation in that space. And some things have come out of it. There's a lot of attention being devoted to what's called the wearable or the implantable artificial kidney. That's quite a ways off, but there is some movement in that direction. That is, for example, Andrew Conklin might be able to walk around with a kidney that's working all the time, an artificial kidney that's working all the time. Instead of going to dialysis 3 days a week and getting tortured in his dialysis chair for 4 hours, he could wear this kidney all the time and have much better replication of natural kidney function. So that's a long way off, but at least we can kind of see it on the horizon now. And I think this Kidney X program is doing something to move in that direction.
That's great. Stanley, did you want to add anything to that?
No, I actually agree with Larry here. But from a payer perspective, we're excited because it gives our members additional opportunities to improve the quality of care. And we know that people who have improved quality of care will have improved cost of care. So it really is a win-win. And Larry's also right, the kidney space has had very little in the way of innovation, drug and or device in such a long time. And now we have new innovative programs on the horizon, everything from home dialysis machines that are much more simple to use, that don't require, back plumbing your house, for example, so that we get more patients actually even doing home dialysis just with that simple, more innovative device that could do, water and mixing solution at point of service versus replumbing your house. So it opens us up to having more patients at home, which, like I said, will improve quality of care and that thereby improving cost of care. So it's a very exciting time.
That's great. And I've got one more question here, and then we're going to move on to the next section. And Andrew, I think this question is best for you. Question here is, can you talk a little bit about some of the benefits and trade-offs on home dialysis versus dialysis outside of the home?
Sure. A lot of patients do see a benefit to home dialysis in that they don't have as many blood pressure drops. They may not have cramps as much, have a better appetite, less fatigue. There are some patients, myself included, that because of so many medical issues that I have, I do feel more comfortable in the clinic. That's not for everyone. So I do believe in patient choice. That's always been one of my biggest things, is a patient should be able to choose which modality and which setting they want to be in.
So thank you for that. Let's actually switch gears now. I want to move on to some solutions. And because over the last couple of minutes, we've talked about a lot of different challenges out there that the patients see, providers are thinking through, plans are thinking through. Andrew, let me start with you. What will help you and other patients the most? And when you think about the audience here, we've got a lot of federal policymakers in the audience. What solutions would you like to see?
One of the biggest things is care coordination. I think if you can make it as simple as you can for the patient to get through insurance, to get transportation, to just get to the clinic or to their treatment, I think is the biggest obstacle.
And have you seen, in addition to the care coordination, is education a part of that too? Do you feel that patients have the education they need, or is more needed to be done there?
I think you can always educate more. Okay. One of the biggest things I think is not necessarily the patient being educated, but maybe family members and the general public as a whole. I hear it so many times. Oh, you just go to a clinic, you come out, you're fine. No, it doesn't work that way. You're in that clinic, you're on that machine 3 times a week. If you're doing the next stage machine, you may be doing it more, 6 times a week. So it's not an easy process. It's not a quick process. And of course, it's not a total fix, because you will always need either dialysis or a transplant.
Yeah. Larry, let me turn to you. These programs are supposed to start next year. You talked a lot about how doctors are starting to really evaluate these and kick around the numbers. How fast do you think providers could actually move forward in this COVID era that we're in?
I mean, this is, of course, a very challenging time for everybody, for physicians, for patients, for all the staff. I think, and the last point that I just mentioned, I think could be a rate limiting step. And that is, as Andrew said, the big focus of all these programs should be care coordination, the total care of the patient. And that requires a lot of folks paying attention to their patients with chronic kidney disease and end-stage kidney disease. We're really short on staff all over the country right now. I think COVID is taking a huge toll on healthcare providers. I know in the hospitals we're all short-staffed, and the staffs in dialysis clinics is really being terribly affected by this pandemic. So to the extent that our staff numbers limit our availability to provide the kind of care that we really want to provide, and that would be essential for the success of many of these value-based payment programs, we're going to be hurting. It's going to be a slow ramp up, I think.
And Stanley, similar question to you. What do you think needs to be done to make sure that we can continue to have this care coordination, have better care coordination, and really just improve care for patients?
Yeah, I want to amplify Andrew here. Care coordination really is key, and that really is the hallmark to Anthem's and CareMore's kind of approach to kidney disease management. And so I'll start by saying we certainly put lots of focus on our members with end-stage kidney disease for dialysis, but we need to also think more globally, and we need to go upstream. And I alluded to this earlier, but I think it bears repeating. We should think about how to expand our CSNP and Medicare Advantage models to include patients with chronic kidney disease. And as previously mentioned, our CSNP models and studies have shown that this, improved patient care coordination and that targeted benefit actually helps people with the ESRD. By virtue of that, we know it'll help folks with upstream CKD, so we can actually do some of those same interventions that they need in order to prevent crashing into dialysis, unplanned starts. And then again, it helps people really get that education they need to understand how to make modality selection, whether they'll be a home candidate, if it's their family or personal needs. So we think about these challenges and ways to improve by saying, look, if we take the same model, go upstream with CKD, put those same folks in CSNP models, again, who haven't progressed to ESRD, we can really change outcomes. We can really improve preemptive transplant rates. We can improve folks who are going home on therapies, or who are going to home therapies. We've been joined by NKF actually in this initiative, so we're working to hopefully get CSNP models in our ESRD CSNP models to include CKD patients. Other things that we thought about here in terms of what we can do to improve care. One of the issues right along with care coordination is engaging clinicians, so doctors, nephrologists, and primary care doctors. A lot of our patients clearly don't see nephrologists soon enough. And is this, chicken or egg? Is it the nephrologist not taking care of them, or is it they're not being referred? But, thinking about ways to, incentivize primary care doctors and nephrologists to really work hand in hand or closer together so that we can really take better care of these people. We know from our experience with the ESRD members, early referrals and an engaged, activated physician partnership between nephrologists and primary care doctors improve clinical outcomes and cost of care. So we'd really like to think about how to activate clinicians more in this space. And then the other point I'd like to bring up, and this is more specifically related to our dialysis patients, and this kind of goes along that kind of social determinant sphere. Insulin dialysis sometimes doesn't fit a person's life. And so we need to figure out ways to liberate the market so that other dialysis venues can exist. So smaller transitional dialysis clinics. So if you have an integrated care delivery system, like a CareMore, for example, we could certainly provide dialysis in certain spots in our organization, especially to provide dialysis so people can transition in and out of clinics, meaning the point is to keep people on home therapies. And so sometimes people will need backup in the center, but we have that if we can have a training transitional type clinic. And then for folks who live in more rural areas, so you think about your folks in some of the larger, more rural counties, like San Bernardino County, California, like many counties in Nevada and Arizona, they don't have access to dialysis as readily either. And sometimes these folks are driving 100 miles a day round trip to go to dialysis. So perhaps thinking about how to do mobile dialysis solutions in markets where patients need it, but can't necessarily spend 2 hours a day on the road.
Helpful. Let me actually ask this question from the audience to all of you. Question is, what do we do about patients before they are diagnosed with ESRD? How can we help prevent people from even needing dialysis in the first place? And all of you have talked about this in some way. We need earlier education and we need more as the disease starts. Andrew, let me start with you. What do you think can be done to prevent people from getting to this stage in the disease?
I think, like has been said, education is key, is the biggest thing. The lowering blood pressure, taking care of diabetes, eating better. Those are all critical things when it comes to ESRD. And then, of course, as somebody also mentioned, having the general practitioners either referring to nephrologists sooner or just taking care of issues before they get out of hand.
Larry, thoughts?
Yeah, I totally agree with that. I think there are interventions that we can make early in the course of chronic kidney disease that can dramatically slow the progression of chronic kidney disease. We know that. We've known it for decades. And there's some new medications. So there's a class of medications that are extremely useful and beneficial in patients who have kinds of kidney disease that are associated with a lot of protein in the urine to remarkably slow the rate of progression of kidney disease. So we've known about those medications for decades. Now there's a whole new class of medication that was developed actually for the treatment of diabetes that turns out to be phenomenally useful in that same situation. And they have an additive effect with the other medications that we were using previously. So we have tools at our disposal to really radically slow the progression of chronic kidney disease in a large population of patients. But we need to see those folks early. If we don't see them until they're very close to end-stage kidney disease, the use of those medications is really trivial. It's unproductive. So we need to see those folks earlier. We know how to do that. And then the other thing we can do is we can try to get people, as Dr. Crittenden said, we can try to get people into transplant evaluation programs early. I mean, there's certain criteria for when you can refer people, but they can get a preemptive transplant. Before they ever require dialysis, they can get a transplant. Never touch dialysis. Wow. Great. You know, but what we need is kidneys. We have about 100,000 people waiting for a kidney right now. 100,000 people waiting for a kidney right now. And this coming year, about 20,000 of them will get a transplant. That's it. So yeah, anyway, we need to have more availability of eligible kidneys. Anyway, those are some of the things that we can do.
Stanley, you can round it out on that question. How do we prevent people from getting to this stage in the disease?
Yeah, no, so I agree with both Dr. Weisberg and Andrew here. And I'm going to kind of sum this up by saying care management. As we care manage folks earlier upstream, we can do all of these interventions by putting the right team of folks around patients so that they are educated and aware. We have activated and empowered PCPs. We have partner nephrologists who are willing to work hand in hand with the care management team. And again, all of this is so that our patients will understand what their risk is. They'll understand why it's important to take their ACE inhibitors, these drugs that actually slow progression of chronic kidney disease, or their SGLT2 inhibitors, which are the new class of drugs that Larry mentioned. We know that these do work. So we need to get patients on them, get their clinician team empowered to actually do this and educate people. And I think that will actually help slow disease progression. And then even those folks that you can't slow progression, because some people will develop end-stage renal kidney disease regardless, those are the patients that you want to have ready for soft landing as they progress into ESRD, and have them ready so that they're not crashing and burning and super sick and ill in the hospital. You've planned it out, you've had them on the right therapies, you're managing all of their comorbidities appropriately, so that in that small subset of patients that you can't slow or delay, you have them on a softer landing place.
If I could just
please.
If I could just mention one thing in that regard, and that is this period that Dr. Crittenden just referred to, that is the transition from chronic kidney disease to dialysis-dependent kidney disease, is a particularly vulnerable moment. It's associated with a very high mortality rate and extremely high cost typically. And so some models have been proposed to really coordinate the care of those patients in that transition period to improve mortality, reduce the cost of care. One was proposed to the PTAC by the Renal Physicians Association a couple of years ago, and the PTAC thought it was a great model, and they recommended its implementation, but CMMI chose not to advance it. So it's just sitting there, but it's a very strong model.
You know, we're about to run out of time here, but I want to combine two questions from the audience and have this be our last one. And it's about, since a couple of you just talked about the transplant system. So the question is, you know, how can we make the transplant system work better? And is part of that, how do we better educate living related donors to donate? What needs to be done to just make that process work better for all? And I open it up to whoever wants to opine.
I'll opine here quickly, and I know I'm on my care management shtick, but it bears repeating again and again and again. As patients are care managed upstream, you give them the chance to actually understand and ask all these questions. There have been a couple of studies that looked at preemptive listing for people for transplant, and if you get people listed earlier, they're more likely to get living donors. versus waiting until they're on dialysis, because then kind of cat's out of the bag and people get comfortable with, oh, you're on dialysis, it's okay. So really this upstream aggressive care coordination, care management, and education from the entire interdisciplinary team will help improve transplant uptake and adoption. Preemptive, especially preemptive transplant, and sometimes populations who are perhaps more marginalized or populations that have these systemic kind of health inequities, if you can get the right decision makers to the table within those families and have those shared decision-making conversations, again, plenty upstream from the crash point, you will also increase your chances of having folks be listed for living-related donor transplantation.
Okay, great. Larry, Andrew, anything else to add on that before we break?
I think the biggest thing is the supply of organs. We really need to work on just a larger number of supply.
Yeah, and I totally agree with that. I think you can see that's really the rate limiting step at this point. But then there are other, we need to align the financial incentives. I'm not going to go into the details here, but it's clearly a financial disincentive to move a patient who's on maintenance hemodialysis in an outpatient facility to a successful transplant. It's a financial disincentive to the physician. That's crazy. That's crazy. Mm-hmm. It would only benefit the patient and society. But right now, the way the financials are aligned, it's much more beneficial to the physician practice and the facility, frankly, to have that patient in the dialysis chair. So that needs to be thought through.
That's right. Well, you can tell by all three of these folks, they have a lot more to say. This is the worst part about doing these is I have a ton more questions and I would love to get more of your wisdom and guidance, but unfortunately our time is up. I want to thank you all. I know this is a very busy time of year. It has been an absolute pleasure to have you guys sharing your insights and wisdom with us. Thank you for doing this. Thank you to everyone who attended today. I hope everyone has a good holiday season and stay safe. Thank you, everybody.
Thank you.